Welcome to Explain, a series of health education programs published by the Patient Education Institute, the leading provider of interactive health education. This video includes general medical information and does not replace the medical advice of your doctor or healthcare provider. If you have questions pertaining to your medical condition, ask your doctor or healthcare provider. Infertility, an overview. Introduction. Infertility is the inability to achieve pregnancy after 1 year of unprotected intercourse. If you have been unable to conceive for a year or more, you may need to have an infertility evaluation. However, if you are 35 or older, you should begin the infertility evaluation after 6 months. Also, if you have very irregular menstrual cycles, or if you and your partner has a known fertility problem, you should probably not wait an entire year before seeking treatment. This patient education tutorial will help you understand the causes and treatments of infertility. Reproduction. In order to understand the fertility tests and treatments you may be offered, it is important to understand how natural conception occurs. This section reviews reproduction. The female reproductive organs are located in the pelvis between the urinary bladder and the rectum. They include the ovaries, the fallopian tubes, the uterus, the vagina. The ovaries are two small glands with two main functions. 1. The production of specialized hormones such as estrogen and progesterone. 2. Ovulation, which is the release of eggs needed for reproduction. Ovulation is the most important factor in conceiving a child. About once a month, an egg matures in a fluid-filled ovarian cyst called the follicle. The egg is released by one of the ovaries into the fallopian tube. If the sperm ejaculated in the vagina after ovulation are healthy, they travel up the female reproductive tract to the fallopian tube and fertilize the egg. The fertilized egg then divides and becomes an embryo. The embryo travels down the fallopian tube into the uterus where it implants into the uterine lining. The uterine lining is called the endometrium. If the egg is not fertilized, the endometrial lining that develops in preparation for pregnancy sheds. This is known as menstrual flow. Infertility. All of the following must occur in order for you to conceive a child. Your ovary must release, ovulate an egg. The egg must be captured by the fallopian tube. Sperm must travel through the vagina into the uterus and up into the fallopian tube. Sperm has to fertilize the egg. The fertilized egg or embryo must travel down to the uterus. The embryo must implant in the uterine lining and develop for 9 months. A problem with any part of this process results in infertility. This section discusses infertility factors associated with the different parts of the conception process. The age factor. Fertility declines significantly in women in their mid-30s and worsens in their late 30s. Some women even experience decreased fertility in their late 20s and early 30s. Fertility declines with age because fewer eggs remain in the ovaries, and the quality of the remaining eggs is not as good. Pregnancy is exceedingly rare after age 45, and miscarriage rates are very high. Ovulation factor. Problems with ovulation are common causes of infertility, accounting for approximately 25% of all infertility cases. Ovulation involves the release of a mature egg from one of the ovaries. After ovulation, the ovary produces the hormone progesterone. Before the onset of menstruation, progesterone transforms the lining of the uterus into a receptive environment for the implantation and nurturing of the fertilized egg. Tubal factor. Open and functional fallopian tubes are necessary for conception. Tubal factors, as well as factors affecting the peritoneum or lining of the pelvis and abdomen, account for about 35% of all infertility problems. Peritoneal factor. The peritoneum is the lining of the pelvis and the abdomen. There are two common abnormalities involving the peritoneum. The first abnormality that involves the peritoneum is endometriosis. In this condition, tissue that normally lines the inside of the uterus begins to grow outside the uterus. This tissue may grow on any structure within the pelvis, including the ovaries, and is found in about 35% of infertile women who have no other known infertility problem. The second abnormality is scar tissue, or adhesions between pelvic organs. This can be caused by surgery or by endometriosis and may prevent the egg from traveling to the fallopian tube. The cervical uterine factor. Conditions within the cervix, which is the lower part of the uterus, may impact your fertility, but they are rarely the sole cause of infertility. It is important for your physician to know if you have had prior biopsies, surgery, freezing and/or laser treatment of the cervix, abnormal pap smears, or if your mother took DES, diethylstilbestrol, while she was pregnant. The male factor. In approximately 40% of infertile couples, the male partner is either the sole or a contributing cause of infertility. Male infertility is often the result of sperm abnormalities. These include low sperm count, varicocele, a swollen vein in the scrotum that impedes sperm development, infections, improper sperm shape or movement. This could prevent sperm from reaching the egg. In short, several factors can prevent you and your partner from conceiving. If you have been trying to conceive for a year or more, it may be time to take the next step toward discovering why you have been unable to conceive and meet with a physician.
Sponsored by the Patient Education Institute. www.patient-education.com. Over 5,000 videos and interactive tutorials.
The initial visit. Both you and your partner should attend the first meeting. Infertility is a shared experience and is best dealt with as a couple. In a typical initial visit, the physician will ask about the frequency and regularity of your menstrual period. The physician will also ask if you have had pelvic pain, abnormal vaginal bleeding or discharge, or any medical illnesses. Also expect questions about prior conceptions, miscarriages, operations, and methods of contraception. Your partner will be asked questions about prior genital injury, operations, infections, drug and/or medication use, and medical illnesses. Your physician will need to know the complete sexual and reproductive history of both you and your partner, including any prior pregnancies. Since at least 25% of infertile couples have more than one factor causing infertility, it is very important to evaluate all factors that may affect either of you. Physicians know that the procedures and intimate questions involved in an infertility workup can be difficult. You should always feel free to make your physician aware of your concerns and frustrations. Usually, each of you will need a complete physical examination following the initial review. Fertility evaluations. Fertility evaluations include age-related fertility, ovulation tests, fallopian tube examinations, cervical and uterine examinations, peritoneal examination, semen analysis. This section discusses medical tests you can have to assess fertility or diagnose infertility. Age-related fertility. Blood tests are now available to determine your ovarian reserve, which reflects your age-related fertility potential. In the simplest of these tests, the hormones FSH and estradiol are tested in your blood early in your menstrual period. An elevated FSH level indicates that your chances for pregnancy may be slim, especially if you are age 35 or older, but does not mean that you have no chance of successful conception. Ovulation tests. If you have regular menstrual cycles, you are probably ovulating. If you menstruate every few months or not at all, you are probably not ovulating or are ovulating infrequently. There are a number of ways to confirm that you are ovulating. You can conduct 2 of them yourself at home: basal body temperature and predictor kits. Basal body temperature, or BBT for short. For this test, you must take your temperature orally the moment you wake each morning for at least a month, then document the temperature under the appropriate date. Normally, ovulation causes a rise of 0.5 to 1 degree in a woman's body temperature. However, some women ovulate and do not experience a rise in temperature. Prediction kits. These urine test kits are designed to detect the surge of luteinizing hormone, or LH, that occurs just before you ovulate. The LH surge stimulates one of the ovaries to release an egg and produce progesterone. Ovulation prediction kits usually detect the LH surge about a day or a day and a half before ovulation, giving you and your partner advance notice of impending ovulation. However, not all women who ovulate will have an LH surge that will be detected using these kits. Some medical exams to confirm ovulation are done by a physician or other medical staff. They include blood test, pelvic ultrasound, and endometrial biopsy. Blood test. This helps confirm whether ovulation has occurred by measuring the level of progesterone in your blood. Pelvic ultrasound. This examination may indicate whether your ovaries are producing follicles. These follicles are fluid-filled sacs or cysts located just beneath the ovary's surface that contain the immature eggs. Ultrasound may also help to document the follicle's collapse, which implies release of the egg. This examination, though, is not done routinely. Fallopian tube examinations. A special X-ray called a hysterosalpingogram, or HSG, can be performed to evaluate the fallopian tubes and uterus. During an HSG, a special dye is injected through your cervix, fills your uterus, and travels into your fallopian tubes. If the fluid spills out the ends of the tubes, they are open. If the fluid does not spill out the ends, then the tubes are blocked. Cervical and uterine examinations. The HSG test, which is used to investigate the fallopian tubes, can also reveal defects inside the uterine cavity, which is the hollow space inside your uterus where an embryo implants and develops. An HSG is conducted after your period stops, but before ovulation. Possible uterine abnormalities that may be identified include uterine scar tissue, polyps, grape-like pieces of the endometrial lining dangling in the uterine cavity, fibroids, an abnormally shaped uterine cavity. Uterine abnormalities can also be seen by a saline hysterogram, or SHG. During this test, saline is injected into your cervix. The saline allows the physician to see the outline of your uterine cavity using an ultrasound. Unlike the HSG, the SHG allows visualization of the wall of the uterus and the cavity at the same time, a difference which may be helpful in some cases. Peritoneal examinations. Laparoscopy is a surgical procedure that helps identify and treat adhesions or endometriosis. Laparoscopy is usually performed under general anesthesia. It is likely that you will go home the same day as the surgery. During the procedure, a narrow telescopic instrument called a laparoscope is inserted through a small incision within or just below your navel. The laparoscope allows the physician to see your abdominal cavity on a monitor and inspect your ovaries, fallopian tubes, and uterus. A dye is usually injected through your cervix to determine if the passage to the uterus and tubes is open. One or more additional smaller cuts may be made above your pubic area. This is so the physician can insert additional instruments to better examine your pelvic organs and treat any disease if found. Semen analysis. To prepare for a semen analysis, your partner will be asked to keep from ejaculating for at least 48 hours. Then, he will collect a semen sample in a cup by masturbating at home or in the physician's office using a sterile cup. The semen is examined within 1 hour under a microscope to determine the volume, movement, and appearance and shape of the sperm. 2 or 3 semen analyses may be recommended over 2 to 6 months if the results are abnormal. In approximately 5% to 10% of couples trying to conceive, all fertility tests are normal and there is no apparent cause for infertility. In these cases, the infertility is referred to as unexplained. Treatment. There are 2 main categories of infertility treatment: non-surgical treatments and surgical treatments. Non-surgical treatment includes fertility drugs, These drugs are designed to either bring about or regulate ovulation. There are many of these medications available. Discuss with your physician which, if any, is right for you. Surgical treatment includes in vitro fertilization, intrauterine insemination, and laparoscopy. In vitro fertilization, or IVF. During this procedure, eggs are surgically removed from your ovaries and taken to the laboratory. There they are combined with your partner's sperm. If the egg is fertilized, the resulting embryo is placed in your uterus. Sometimes the embryo is placed inside of another woman's uterus. This is called a gestational carrier. The other woman becomes pregnant so that the couple can have a child. Intrauterine insemination, or IUI. In this procedure, sperm are injected directly into the uterine cavity in order to bypass the cervix and place the sperm closer to the egg. Laparoscopy. Along with the laparoscope, surgical instruments are inserted into a small incision in your abdomen. These instruments are used to treat problems like scar tissue or blockage of the fallopian tubes. Older women tend to have a lower response to fertility medications and a higher miscarriage rate than younger women. The chance of having an abnormal fetus, such as one with Down syndrome, increases with age. Because of the effective age on pregnancy and birth rates, it is common for older couples to begin fertility treatment sooner and, in some cases, to consider more aggressive treatment than younger couples. Possible treatments for age-related infertility in women include fertility drugs plus intrauterine insemination or in vitro fertilization. In cases where the treatments fail or are predicted to have a low chance of success, egg donation is an option. Egg donation has a high chance of success regardless of your FSH level. For couples who have not succeeded with fertility treatments or who choose to forego treatment, adoption is also an option. Ovulation treatment. If you are not ovulating, your physician may prescribe drugs to induce ovulation, as well as order tests to determine why you are not ovulating. Your medical history and physical exam will help determine which tests are appropriate. More potent fertility drugs, which are given by injection, may be prescribed if oral therapy fails. Treatment. If the HSG shows blocked fallopian tubes, your physician may recommend a laparoscopy to assess the degree of tubal damage. If the tubes are found to be blocked, scarred, or damaged, surgery can sometimes correct the problem. Although some tubal problems are sometimes correctable by surgery, women with severely damaged tubes are so unlikely to become pregnant that in vitro fertilization, or IVF, offers them the best hope for a successful pregnancy. Because badly damaged tubes may lower IVF success rates, your physician may recommend removal of the tubes prior to in vitro fertilization. Cervical factors. Intrauterine insemination, IUI, directly inserts sperm into the uterine cavity in order to bypass the cervix and place the sperm closer to the egg. Hysteroscopy. Problems with your uterus may interfere with implantation of the embryo or may increase the incidence of miscarriage. A hysteroscopy is a procedure in which a lighted scope or hysteroscope is inserted through the cervix into the uterus. It may be required to further evaluate and possibly correct uterine structural problems. Although it is reasonable and sometimes advisable to perform laparoscopy to identify and treat pelvic disease, this procedure is not routinely performed in an infertility evaluation. Laparoscopy is expensive and involves some surgical risks. You and your physician should discuss whether laparoscopy is recommended in your particular case. The risks of laparoscopy include but are not limited to bleeding, infection, scarring, and injury to internal organs such as the intestines. These risks, however, are not common. Male treatment. If your partner's semen analysis reveals abnormalities, he may need to consult a urologist or other physician who specializes in male infertility. Treatment for male infertility may include antibiotic therapy for infection, surgical correction of varicocele or obstructed ducts, or medications to improve sperm production. In some cases, no obvious cause of poor sperm quality can be found. Intrauterine insemination or IVF may then be recommended. direct injection of a single sperm into an egg, or intracytoplasmic sperm injection, ICSI, may be recommended as well. If no sperm are present, your physician may recommend testicular sperm extraction, TESE, and ICSI. If no sperm are present in the testes, your physician may discuss using a sperm donor. Insemination with donor sperm may also be considered if intrauterine insemination is not successful or if you and your partner do not choose to undergo IVF. Unexplained infertility treatment. Fertility drugs and intrauterine insemination have been used in couples with unexplained infertility with some success. If no pregnancy occurs within 3 to 6 treatment cycles, in vitro fertilization may be recommended. There are many treatments available to you. Your physician will describe the odds of success with each of these treatments. However, it is up to you to decide how far you will go in your attempts to conceive. Coming to a joint decision with your partner about goals and acceptable therapies is important. It is also important to know that feelings such as sadness, anger, guilt, and anxiety are common responses to infertility. Talking about these feelings with your partner may help you determine the best plan for you.
If you like this video, please like and share. For similar videos, subscribe to our channel.
Summary. Sometimes the factors affecting your fertility are easy to detect and treat, but in many cases a specific reason for infertility may be difficult to identify. After a full evaluation, your physician can give you a reasonable idea of your chances of achieving pregnancy with various treatment options. The choice of which treatment to pursue, if any, is strictly a personal one. Side effects, costs, the risk of multiple births, which is increased with some infertility treatments, and expected success rates are important factors to consider when choosing a treatment plan. It is helpful when beginning fertility treatment to develop a long-term plan with your physician so that you will have an idea of how long to pursue a particular treatment before considering moving on to more aggressive therapy or stopping treatment. It may be necessary at times to temporarily cease therapy and begin again at a later date. Thanks to the many options existing today, including advanced reproductive technologies and adoption, most infertile couples will be able to experience the joy of parenthood. Thank you for using Explain.